Introduce the next speaker.
Thank you. Thank you very much, Dr. Call. So next speaker will be Professor Mayank Goyal from Calgary. He is a well-known figure in field of acute stroke management, especially with the endovascular treatment. He has a lot of interest about managing patients with endovascular therapy. Not only that, extending it further, doing the ESCAPE switch time and now ESCAPE NA1 trials. He is chair of Hermes collaboration and he's inventor of imaging techniques, which includes multiphasic CTA. Mank is an AV teacher and he travels extensively around the world. You need to keep a track of him, whether he is in Canada or he is in Asia. So Mank will be talking about management of patients with large and medium vessel occlusions. Over to you, Mank.
Thanks so much, Vijay, for the kind introduction, and good morning, everyone. It's great to be at the Indian Stroke Summer School. Excellent. So MeVO is medium vessel occlusion, and I've deliberately sort of changed the title slightly. So these are my disclosures. I work with certain device companies, but the guidelines for EVT are now so clear. I'm not going to spend time on it. And in fact, I wrote this article a few years ago that the problem with large vessel occlusion is not which patients we should treat. The problem is now which patients should we not treat. So given that, I'm not going to spend much time on large vessel occlusion. I'm going to be focusing primarily on MeVOs, medium vessel occlusion. How do we define it? What's the clinical presentation? What's the clinical course? What are the treatment options? How do we think about level 1 evidence? How do we do sort of the imaging? So we wrote this article relatively recently where I think that MeVO, medium vessel occlusion, is the next frontier from the point of view of endovascular treatment. And in this article, we defined it as that first level is that there has to be an occlusion, which could be A2, A3, M2, M3, or a P2, P3. And some people think that if it's a large, somehow a combined PICA, ICA kind of combined branch, maybe that could also be considered MeVO. But frankly, at the current moment, based on technology and all, most people will not think of cerebellar branches as a MeVO. But in addition to the occlusion, you also have to think about a corresponding clinical deficit. So firstly, there has to be a clinical deficit that is commensurate with the occlusion. But the other part is we defined it as NIH more than 5, equal to or more than 5, or if it is less than 5, there's disabling deficit. As the previous speaker mentioned, you can have complete aphasia, but the NIH will not exceed 5. So for that reason, you can have an M3 occlusion with complete aphasia, which is completely disabling. But at the same time, that is why we're moving away from this idea of the NIH stroke scale as a sole way to define significant MeVO. There is also the issue of primary versus secondary MeVO. And what do we mean by that? Primary MeVO is the clot escapes from somewhere, carotid or heart, and straight away goes into a medium-sized occlusion. The second is that was an M1 occlusion that broke away and went into the M2 occlusion. So we recently put on a definition for secondary medium vessel occlusion. We call it when clots move north. And what are the different ways based on timing, based on discrepant infarct, based on sort of if the patient comes from a primary stroke center where the imaging was one way, now comes to another place where the imaging is another way, so on and so forth. That's how we define secondary MeVO. And that will become critical as we move forward from the perspective of design and conduct of a MeVO trial, where we'll primarily be wanting to enroll primary MeVO. We also looked at it from the point of view of secondary MeVO versus primary MeVOs. How does it play out in terms of outcomes? So here's the way that we looked at it, that if suppose you have a MeVO and the infarct is commensurate with the MeVO, then we say, okay, that's fine. It was a MeVO that caused the infarct. However, let's say there is an M3 occlusion and there is a basal ganglia infarct, then the M3 occlusion could not have caused the basal ganglia infarct. So that is a discrepant infarct pattern. So for example, this person, there is the MeVO that is supplying this area. The follow-up infarct is here. So this MeVO cannot cause this infarct. So we called it a secondary MeVO. And then we looked at how these different things play out in terms of sort of different kinds of discrepant patterns. I'm not going to go into the details of the discrepant patterns, but as you would expect, it does influence outcome. So in this case, for MRS02 in our data set, for primary MeVO, the good outcome rate was 71%, while in secondary MeVO, it was 56%. And this is not a surprise. This is intuitive. This makes biological sense. There is an infarct which is not in the territory of the MeVO. So it is expected that either there's a shower of emboli or there was a more proximal occlusion. So essentially, that is sort of a way to think about it. It is also important to note that in our data set, 20 to 40% of all MeVO strokes were secondary MeVOs, which were more severely affected and have worse outcomes. The other part that is there is that there is this thinking process related to that MeVO strokes are going to be sort of relatively mild. So we looked at all our data set MeVO strokes. And in fact, as you can see, they are mild compared to the LVO strokes. As you know, in all the papers that we published, Hermes, Escape, etc., the median NIH was 17. And here the median NIH is much lower at the 7-8 category. But even then, it is substantial. It is substantial. It's not like in the 1-2 category. So many MeVO strokes will still have substantial deficit associated with them. What is the clinical course of MeVO stroke? So we had a unique data set where not only did we have sort of the fact that they were MeVO strokes, the second thing we had is whether they got TPA or not. And then we set up the study where patients had a 4 to 6 hour repeat CT angiogram. So we could get to know whether the vessel recanalized or not. One way to think about MeVO strokes is rather than thinking about MRS02, one could think about MRS01. And if you look at MRS01, it's actually only 50%, which means 50% of the patients do not have an excellent outcome in MeVO strokes. We also looked at it from the point of view of what do people think about decision making, etc. And we set up this worldwide survey, which some of you may have participated in, where we looked at it in terms of sort of, like if there's a 88-year-old with so on and so forth and a history, and there is an M2 occlusion. What we did find is from a worldwide perspective, more than 50%, even sometimes more than 70% of people were willing to seriously consider endovascular treatment. Obviously, it does change based on continent, based on infrastructure, based on which city you're applying from. So coming back to the clinical course of MeVO, what we did find was that if with and without alteplase, the outcomes are different. Alteplase does have an effect. It does improve outcomes, but even in the presence of alteplase, there was 53% that had an MRS01, which means 47% did not have it. The second part, which is even more relevant, is that because we had the 4 to 6 hour CT angiogram, whether the vessel recanalized or not. And as is true in every possible ischemic stroke that we deal with, opening the vessel helps. So if you can open the vessel, there is a substantial improvement in the outcome. Obviously, these are patients that were not treated with endovascular treatment. But what was very impressive was that we have a general thinking that, oh yeah, big strokes, TPA doesn't work, small strokes, it works. But even for small strokes, when you do an early repeat CT angiogram, only 50% of the vessels open up, as opposed to in the ones that were not giving alteplase. So, we have a long, long way to go in terms of getting these vessels opened quickly. Obviously, you guys are probably familiar with this paper. This is from the Hermes analysis that we wrote up, which was on the M2 occlusions. And just to remind you that in the Hermes papers, basically the data was such that it was an expectation that most patients will be LVOs. So the patients who do have an M2 occlusion within the Hermes data set are probably those that were M1 looking M2s. So they were probably big M2s where we were able to show benefit. It's interesting, we did another survey and stuff where we looked at this idea of that whether the person is TPA eligible or not, how does it influence decision making? And it actually does. Many people on the survey told us that if the patient is TPA eligible, I'll be more hesitant about EVT. I'll give the TPA, wait and see what happens, and then sort of decide from there. We also looked at it from the point of view of that what are the factors that people say not to treat with EVT? And as expected, the two biggest ones were benefits are too small and there is insufficient evidence. And this is something we are working on to fix. So move to better evidence. And obviously the benefits being too small, we have to sort of think about it, how to choose the patient so that we are able to maximize and compensate for the risk that EVT has. We also looked at in terms of sort of what are the various treatments that people use for MeVO. One thing to remember is the endovascular treatment field is changing exceedingly rapidly. And as more and more evidence comes out, more and more industry partners are able to develop devices which are suitable for it. So do we have a perfect MeVO device? Probably not. Will we have a perfect MeVO device? Yes, there'll be substantial improvement in the next 12 to 24 months, and many more of our industry partners will come up with MeVO devices. The other part that was there was I realized that we did not have a perfect scale for classifying reperfusion. So this is a recent paper in JNIS that we wrote where we classified the idea of how do we talk to each other when we are dealing with a MeVO stroke and you're successful, not successful, there's a partial occlusion. How do we talk to each other in terms of calling it 2A, 2B, 2C, and so on and so forth. So this is just a map that we made in terms of that depending on where the occlusion is and depending on what the denominator is. So you first need to define the denominator and then create a system of communication with each other. In terms of imaging, one important part to realize is that interpretation of MeVO on CTA is much, much tougher than it is for LVO. And most of the automated softwares that exist right now, LVO detection softwares, have a very poor performance with MeVO. Not to mention the fact that there's the inherent variation of location compared to an LVO stroke, where pretty much it's M1. Here it could be in the ACA, it could be in the PCA. And the other part that is there is the traditional aspect score, which, as you guys know, came out of sort of Calgary, is not very applicable in MeVO. If you have an ACA stroke, aspects you cannot communicate with each other, which means we have to keep that in mind. So we need to think about modifying the imaging technique. And one way to do it is you could start doing CT perfusion on everyone, but that has practical problems. Most hospitals do not do CTP, or post-processing softwares are expensive. The other big problem I find with CTP is I don't trust what they call core. And people send me cases from different parts of the world, and which the CTP had a big core. You open the vessel and the patient improves, and the follow-up doesn't show an infarct. So I hate to exclude patients on the basis of CT perfusion. But what do? We do a CT multiphase CTA. And what happens is, because of the occlusion, there is holdup of contrast in the second and third phase. And in fact, our residents now look at the second and third phase before they look at the first phase. And then there are some additional technologies that are coming up. So as an example, this is an M2, M3 occlusion. And if you look at the third phase, there is this asymmetry of contrast over here. The moment you see this, there is an occlusion, you go back and you sort of look for it. Another similar case, you look at this asymmetry, there is this asymmetry from here to here in the third phase. And the moment you see this asymmetry, something is going on, let me look for it. And then you go sort of find the occlusion. Similarly, here's another one, which is like a broken up kind of plot. But again, you see the asymmetry left to right, and you know that there's going to be an occlusion there. And obviously, having the clinical information helps as well. If the patient has right-sided weakness, for example, you're looking at the left hemisphere. It works for ACA as well. For example, here there is clear asymmetry. This vessel is staying on, and there is an ACA occlusion that you can sort of determine that way. The General Electric, as an example, has this software called Color Whiz. So what they do is they summate the three phases of the multiphase CTA and give it a color coding based on time delay. And the moment you see a different color, you know that there's going to be a MeVO, medium vessel occlusion, in there. So that is a very successful software, and there are at least probably 100 hospitals now in North America that are using this software. We are developing something in our team, which is from the multiphase CTA, which is basically like a mean transit time map. And based on your knowledge of anatomy, for example, if you see this kind of a map, you know that there's going to be a PCA problem. So that's another thing we're developing. We are probably 1 year away from commercial thing, but I'm part of a team that is developing it. What about the EVT technique for MeVO? So what are the challenges? The first thing that is there is the devices have not been optimized for medium vessel occlusion. For example, a regular sized distal access catheter may be too large to reach the distal vessels and may not be long enough. Sorry, I have a typo here. It's too short, it should say. And then is there a possibility that you can bring the TAC up after the fact? So there is this technique which people talk about. We call it D-badass. Other people call it Bemp, B-E-M-P, which is essentially goes like this, that you have a MeVO over here, you bring the microcatheter, you sort of get to the microcatheter with the deploy the stent retriever, and then after the stent retriever is deployed, you sort of then bring up the distal aspiration catheter. So what are the steps? You deploy the stent retriever, then you pull this microcatheter out. You pull the microcatheter out of the body, so the microcatheter is gone. Then you blindly bring up an aspiration catheter. You blindly sort of stabilize everything and bring the blind exchange maneuver. And then you use the wire of the stent to take the aspiration catheter all the way till there. So now you have a traditional sort of badass technique. You have a balloon guide catheter, double aspiration, bring the stent retriever out. The other thinking that is there is this also makes it a bit safer and makes it more effective. So the other part that we've written about and other people have written about it is so I forgot to mention that generally we recommend that always use a balloon guide catheter. There have been tons and tons of data on this idea of balloon guide catheters are better. And in fact, we recently wrote an editorial on it, which came out last month. So there's this issue that happens that if you have an ACA like this, and what happens is the stent gets stuck over here. And as you start to pull the stent, it moves the vessel this way. And one of these perforators may rupture. So a theoretical advantage is that if you have a distal aspiration catheter there, it changes the direction of the stent pull, and it does not cause the same degree of traction on the microvessels. Now, this is theoretical. I feel like it is true. Currently, I don't have any evidence to support it, but that is what I'm using in my practice most often. Doesn't always work out, but that's what I try to do. So this is the same thing which we've described in sort of the D-badass technique. We call it. It's the same as the Bemp technique, and so they have different names for the same technique. So this is a case just by coincidence from yesterday. Yesterday I was on call. NIHS was 17, left-sided weakness, 52-year-old male. And there were already some changes. The patient got transferred for around 2 hours from here. These are all the changes in the temporal lobe, and they look pretty dark. So you start thinking about, okay, well, is it worth it, not worth it, and stuff like that. But the NIH is 17. So the way I think about it is, and by the way, this patient was not TPA eligible because of being on Coumadin. So NIH of 17, it's there, but I say, well, the NIH is 17 anyway, and it's right hemisphere, might as well go sort of open the vessel. I know that the M1 is open, and I sort of have a quick look at it in terms of sort of what the collaterals are like and stuff like I showed you. Anyway, I go in, it turns out that there is an M2 occlusion here and M3 occlusion here. And then essentially sort of you systematically go into it, get into one vessel, open it up. Then there's still a second vessel that is occluded, went into the second vessel using standard technique. This is the solitaire deployed over there, bring the aspiration catheter up, and then open the second vessel. And essentially the beauty of it is, even though this was already dead, as you know, as I showed it to you earlier, but the beauty of it is that today's the patient's NIH is 0. So that is the power of the treatment. But now that the treatment is so powerful, obviously there's technical considerations and choice of patients and interpreting of the CT angiogram. But it also brings us the struggle of how do we convince ourselves to randomize this patient when the randomized trial starts off. And we are starting a trial, Escape MeVO, which is basically like the Escape trial where we'll randomize all these people. So it's the same old-fashioned days from 2013, 2014, the struggle of sort of feeling like you know the answer to the question, but at the same time you have to randomize to be able to produce level 1 evidence. But this time there is the added complexity of that there probably is a higher risk of complications with endovascular treatment when we get into these small vessels, and how do we sort of compensate for that? Do we need greater use of general anesthesia? Do we need to have better devices? Should we wait for better devices? Do we need better training? What are the kind of patients we need to choose? What is the way that we maximize the appropriate choice of patients? And these are all the things that we're struggling with right now. We have started Escape MeVO. We are sort of going through all the paperwork. We've chosen our sites. We are submitting to ethics. We are hoping to have the first patient randomized in November. There's another parallel trial which is being led by Switzerland. I see Patrick Michel is on this group as well. So I think it's being led by the guys from Basel. So we are in communication with each other in terms of sort of making sure that we have set it up in such a way that later on we can think about merging data at some point in time. So in conclusion, the clinical course of MeVO strokes is not as benign as one would think. And, the traditional teaching was LVO strokes are bad, smaller strokes, TPA works, and don't worry about it kind of thing. The effect of altiplase is limited. And as you know, the previous speaker talked about it, Dheeraj talked about it in terms of the tenecteplase story and see how it all plays out. And it's possible 2 years from now, we move over from altiplase to tenecteplase. And maybe there is a slight difference, but I don't expect tenecteplase to be like a magic drug. There's limited data on the safety and efficacy of endovascular treatment in MeVO strokes, but many people around the world are treating it and want to treat it. And because they are treating it and wanting to treat it, it is a struggle from the point of view of a randomized trial. And, this is not a new thing for us. We fought these struggles before and we'll collectively fight them again. Detection of MeVO is much tougher on single phase CTA. If you guys have CT perfusion, that's great. But if you don't and not using it, think about moving over to multi-phase CTA. If you have a GE scanner, think about using this ColorWiz software, which is great. And we do think MeVO is the next frontier. And we do think that if we are able to successfully move it to level 1 evidence, we will have a substantial impact on improving the care of our patients. So I'm going to stop here and thank the organizers. And I just want to let everyone know that the story of neuroprotection, which we've been working on, the Escape NA1 trial, which we published in Lancet. Now we're doing a follow-up trial, so to speak, the second trial that is called Escape Next. We have 55 patients enrolled. The trial is going quite well. So hopefully in 2 years, we may have an exciting story to talk about from a neuroprotection standpoint. Obviously, I don't know the answer to that question, which is why we are doing the trial. Thank you to the organizers. Vijay, over to you.
Thank you, Mayank, for a wonderful talk. Are there any questions or do we have time for a question? Mayank, I just have a very, very simple question, as a clinician's point of view. When it comes to MeVO, it's all determined by the location or all determined by just the severity of a stroke, NIHSS. The same MeVO can have an NIH of 4 and the same MeVO can have an NIH of 16 also. So do you determine according to NIHSS or just the location?
Come on, Vijay, you are the neurologist. I'm just a plumber. I'll let you figure it out. And no, but jokes aside, the fact of the matter is, the way to think about it is that whether we can safely open it, one thing. The second thing is that whether the deficit is substantially bad or not. So that is the way to sort of think about it. And if you think about it, what we don't want to do is that we do a trial where we include only the NIH of 16s, but then later on, we have no idea how to treat the NHO4. So we have to be sufficiently inclusive in our trial design that it can substantially impact the practice of medicine after the trial is done. So that's the problem I have with the late window trials. The late window trials, Dawn and Diffuse 3, were so selective in the patients that they did that practically speaking, we don't follow the Dawn Diffuse 3 criteria at all.